Good morning, everyone. Thank you for getting on our Zoom call this morning. For those of you who don't know me, I'm Shelby Cheney, the Membership and Program Coordinator for the Troy Chamber. Today we have two speakers joining us. Throughout the Zoom call, please feel free to put any questions that you have in the chat, and we will try to answer them throughout the Zoom or at the end. First, I would like to introduce Tom Parker, the President of Upper Valley Medical Center and Chief Experience Officer for Premier Health. Thank you, Tom, for being with us today. We greatly appreciate it, and thank you for being a community partner. I'm going to go ahead and hand it over to you to give us an update.
Well, thanks, Shelby. Happy Wednesday to everybody. I'm privileged to have the opportunity just to provide a quick overview of activity here at Upper Valley. And I want to qualify my remarks to make certain that what you recognize is that I'm going to speak to the experiences of both our nursing homes and the hospital. I don't represent Miami County Public Health. I believe that the experience that we've had, which is a significant decline in the number of patients presenting with COVID-19-like symptoms or diagnosis, that those numbers continue to be very, very small and on the decline. I believe that would be validated by Miami County Public Health, but I am not speaking for Miami County. So with that, if you will, qualifier, let me just assure you that operations have stabilized completely, both in the nursing homes and at Upper Valley Medical Center, and remain very stable. All of our emergent elective procedures and surgeries have reopened, and we are very busy and remain very busy. Our visitor screening processes continue to be in place, and this is really just out of a continued abundance of prevention and precaution to keep staff, physicians, patients, and visitors safe in any and all of the Premier Health facilities that we operate. One of the things that we are continuing in all of our facilities across Premier is mandatory universal masking. So just as we're now seeing the governor's order, which will convene tonight at 6 p.m. for masking in communities and counties in which outbreaks or increases in COVID-19 symptoms have now been reported, we have sustained the requirement, of course, of universal masking in all of our facilities. The other thing that's different, and this is important for everybody to understand, that in March, when we began to experience the arrival of COVID in the region of our state here, what we were most concerned about, if you think back in time, was access to needed inpatient and ICU beds. It was all about capacity and building capacity. Since then, Region 3 of Ohio has worked with extreme collaboration across our area, and capacity is not an issue or concern at this time. And honestly, admittedly, I cannot imagine that we would be hit with a surprise secondary or third stage surge that would create capacity issues. We are better organized, better planned, and better prepared as a county and a region to address this pandemic going forward. Additionally, we had issues with personal protective equipment. Our PAR levels have all increased, as has our very judicious use of PPE equipment. We know how to use it more effectively, efficiently. And when you add all these factors together, what it suggests is even if we were to find ourselves in an increase of COVID-19 cases, we are far more prepared to manage our way through it. Next, I will share with you that although Montgomery and Butler counties have reported increases of sustained new case growth in those respective counties, that's not the experience through the lens of Upper Valley Medical Center nor Premier Health. Miami Valley Hospital is again experiencing an increase in COVID-19 suspected or confirmed cases, but Montgomery County is one of those reported counties in the state where increases are now being experienced. Across our network here in the north in Miami County, we remain very busy, and although our emergency department is busy, it is not busy with COVID-19 symptom patients. It is busy with respiratory-related illnesses, heat-related, exertion-related chest pains, not COVID-19. So our ED is busy, but it is the predictable busy of the seasonality of illness, accident, injuries, not COVID-19. And in fact, what I can share with you is that in recent weeks, and I really probably should have gone back and looked at it, but this is at least the most recent 30 days, Shelby. We are averaging anywhere from 0 COVID-19 confirmed cases in the hospital to perhaps one or two patients per day that are COVID suspected or COVID confirmed. Far fewer numbers than what we experienced at the onset of this pandemic in March. So I'm going to close with a couple of comments of, so what have we learned in really the past 110 days? What we've learned, not just in Miami County, but across our region, is that the spread of this virus, in fact, can be contained, but it takes personal responsibility and accountability from all residents in all communities in order to prevent the unnecessary spread of this virus. We've learned that masking and social distancing are the keys to containing the spread of this virus. In fact, we know the governor, we know the recent experience in Ohio, the highest infected age groups right now in Ohio are 20 to 29-year-olds. That's our at-risk population. That is who is becoming infected. So if you fall outside of the 20 to 29-year-olds, you're in a safer age group. Secondly, what we understand, and a big contributor to the current surge, if you will, again, or the increase in cases, it's the social gatherings that people are participating in, or maybe even hosting. So when we eliminate and reduce the social gatherings, when we practice masking, when we practice social distancing, we can and do contain this virus. The last thing that we learned in healthcare, and it probably should not have been a surprise, but it was a surprise to us, it was that once again, we have demythed the belief that persons aged 60 years and older are not comfortable using technology to consume healthcare. Virtual visits are here to stay. There is a space for telehealth, for diagnosis, for care, for treatment, and it has been well adopted by all age groups in the US. And that's been a really good finding for us across Premier Health. And we have responded and adapted, implementing that technology on a much broader band at this time. So that's kind of an overview. I'll stop there and open it up if there are any questions or comments, Shelby.
Awesome. Well, thank you, Tom, for sharing that with us. If anyone has any questions, please feel free to unmute yourself or put it in the chat. We'll wait here just a couple minutes and see what comes up. Hey, Tom, are you guys letting visitors come in yet?
Absolutely, Shelby. So visitors are permitted to come to the hospital. And again, we do screening with visitors and we require masking.
Well, I don't think we have any questions, but I just want to thank you, Tom, for taking the time out of your day to be with us and giving us an update.
Thank you, Shelby. Appreciate all the work of the chamber.
All right. Next, we have Ned Clare, the System Vice President at Premier Health. Nick is going to share some information related to tracing and testing of COVID-19.
Yeah, so let me try to get my PowerPoint presentation.
Should be good.
Yeah, I can't find it. All right, let me try again.
Okay.
There we are.
Again, everyone, please feel free to put your questions in the chat. Nick will answer them at the end. So I'm just going to go ahead and turn it over to you.
Yep. All right. So real quick, my name is Ned Clare. I am the Vice President of Lab Services for Premier Health and CompuNet. I got a fruit fly. I'm at UD right now, so I apologize for the fruit fly. But I am the vice president over Premier Lab Services and CompuNet Lab Services. And we've been busy the last 5 months. And I just want to give you a little different perspective as to what Tom alluded to in regards to preparations and what the hospitals are experiencing. I want to come at it at a different point, which is you being the leader of an organization. And just to kind of try to educate you a little bit on COVID-19 as an industry and kind of also within our region. I'm not a doctor, so I don't want to play that at all, but I have been working in the lab world long enough to understand what is going on with COVID, because we are doing all the COVID testing for all of Premier, but also for many other hospitals, many other physician groups, because we are a reference regional lab. So other hospitals rely on us, Premier relies on us, physician offices rely on us. So so that's what we're gonna try to do in the next 10 minutes. Shelby, is that okay? I'll try to do that. The timeline of testing. And I'm not going to try to be like Fox or CNN or NBC News. I'm just going to try to give you an update on the timeline and what I see as something that might be important. Number one is March 17th is kind of like when things got a little hot around the region. This is when we knew cases were starting to be positive. This is when we, as a community, felt like we needed to quickly start being able to test and to set up some type of community testing site. The reason being is because obviously if you're positive, you are contagious, and many physicians and many companies do not want those individuals to come into an enclosed area that would get other people sick. So every office in the region said, we don't want these patients to come into our office. Have them go to a mobile site. And that's when you started seeing all these testing sites come into reality. That started on March 17th. April, and that's also when we started seeing a climb of patients in the ICUs with an unknown virus. We knew it was SARS, but we didn't know how to test for it. We didn't have the instruments, and we were quickly responding. On April 3rd, this is when we can safely declare that is when we caught up, meaning at CompuNet, Premier, even Kettering, even Dayton Children's, we as a region started to receive instruments that would be able to test the SARS based on demand. A lot of physicians were asking for it. A lot of hospitals were asking for patients to be tested. This is when we as the lab industry were able to sufficiently test in a turnaround time that was ample enough. Our turnaround time in the beginning was 11 days. By April 3rd, we were down to 2 days. On May 4th, that's when we at CompuNet brought together another testing methodology, which is called IgG antibody. This is looking back to see if the individual had it. This doesn't mean they have it today. This means they had it. And it goes from a virus. Once the virus is killed off, it goes into your bloodstream, and your body has basically built an immune system to it. And that's what we test for. And then on May 11th, we felt we had enough instruments, enough supplies, enough people, enough everything to do universal testing, which means that we can test anybody that's symptomatic, asymptomatic. If you come into the hospital through the ER, if you go into surgery, we will test you. Once May 11th came, we were able to handle the demand 100%. This picture here I've used many times because it kind of shows you in a picture how the virus works. Let's see if I can get here. Oh, there you are. Okay. So there's 2 stages of the incubation of the virus as an individual. And as you as a leader of an organization, or you as living in a community, there is the time when you have the active virus, and then there's time when the virus has been killed off and that you are carrying antibodies. So there is no safe date to tell you how long an individual has the virus. But I can tell you, with the normalcy of an individual, we are looking at from 0 to 14 days. That is the part that's under the incubation and the early acute phase. It's basically the light blue and the dark blue period. This is when an individual who is socializing with another individual who might get the virus, whether they didn't wash their hands, whether the virus was absorbed orally, through the nose, through the eyes, through the ears. That individual has an incubation period where that's between 0 and 4 days. And then day 5 is when day 4 you might have a temperature, day 5 you might. So it kind of starts building, as you can see from the light blue and the dark blue. That is when that's the test that we do where we are actively testing to see if you have COVID. We use the nasal pharyngeal, which is the swab that goes all the way up the nose for 10 seconds. It is not oral. It's also using instruments that are highly accurate. You got to spend a lot of money on these instruments to make sure that you have accuracy. But this is the time frame when you are carrying the virus and you are contagious. At that point in time, you see the IgM. This is the purple, if you will. These are the first fighters. This is the antibody that your body produces to fight hard. They usually die off because they're the early fighters. And then, of course, the IgG antibody kind of comes in at the end of the day and says, okay, I'm here to stay, because the IgM came in and did its job. We do not have absolute conclusive evidence how long the antibody will be in you, but think about it as a flu. If you get the flu in November, let's say you got the flu shot, but you still get the flu. You get the flu and you have it for 7 days and you get better. And then your body builds an antibody based on that flu strand. That flu antibody is with you for years. It's not with you for 70 years. It's not with you for 20 years. It's with you maybe for 10, 5, 10, 15, however long it's going to last. But obviously, we just don't know how long it's going to last because we've been in this for only 12 months. But kind of look at this as a flu. The other important part is the question is can you get it again? Absolutely, you can. The odds are very small, but you can. If you do, much like the flu, your body already has the antibodies geared up. And if you do get it again, you would get it for an insurmountable period. If not, you would not even know you have it, but you can. So does this screen make sense? This is kind of showing you what we test for 14 days. This is what we're testing. The PCR is the nasal pharyngeal, and that's through your respiratory process. And the antibody is the blood. That's when we draw blood because it's not a virus anymore. We're testing for antibodies. This seems to be very helpful for many people. This is a typical picture of a machine that we're using, which is the Abbott, and this is the size of a machine that we're using. In the reference lab world that we are in, having quick, small machines is great, but having a high, sensitive, specificity, accurate machine is what our reputation and/or anybody, LabCorp, Quest, CompuNet, Kettering. These are machines that are highly sensitive, and they are the best in class. The smaller ones is what is obviously the quickest, but at this point in time, I will communicate to you the science behind this. We at CompuNet would without a doubt forfeit 2 hours to make sure we get the result right. These are the machines that hit the market pretty loudly. But yet they've also had FDA bulletins come out saying, hey, these machines are very quick and easy and you can put them in on a counter, but the results are not accurate. And we at CompuNet are watching this in Premier and Kettering and Dayton Children's. We're looking at these with a fine-tooth comb, because meeting the market need of a 15-minute turnaround time is great, but accuracy in our eyes is more important. So we keep looking at these. There are vendors out there that also will not go to market until they have the appropriate accuracy that's needed. And things are changing daily. So be on the lookout for things like this. I don't represent any vendor. I don't represent any organization other than Premier, but this is where we will get to. This is where we have to get to. But it's just the industry is moving pretty quickly. Whoop, wrong way. So if you go back to the blue, if you go back to the bell curve, on the PCR, that's the active COVID test. We've performed 33 of these as of Friday. So this is about 4 days old. We're up to about 35,000 now. Antibodies, we've done actually about 14,500 now of these tests within the region. The positive rate, and we don't use positive as a term, we actually call it not detected. The not detected rate for us is 5.13 right now. 5.13% of these patients have been positive. There's been a lot of discussion in the media, through the governor, through everybody, about a higher positive rate. We are not seeing that. We are testing more. In the very beginning, we were testing maybe 100 patients a day. We're now testing 1,000. If you have a 5% rate, if you test 100, you get 5 patients. If you test 1,000, you get 50. So we are, in fact, seeing more patients that have it because we are testing more. The percent is not higher, and that's pretty important. On the IgG, this is a little lower. We have people who swear, I had it. I know I had it. Retest me. This rate is about 4%. So every 100 patients that we see come in for the blood draw who said, listen, I was sick in February, I can guarantee you. And it's kind of a running joke because we kind of say, okay, we'll bet you a coffee. And some do, 4% do, but 96% don't. For CompuNet, without a doubt, having more access is the name of the game. We got at our PSCs, I'm at the UD collection site right now. You know, having these testing sites is huge. The UD collection site is extremely busy. We're having people wait over an hour. We used to do 200 a day. We're now doing 400 a day because we're testing more. We're going to put more testing sites around the region. We have to. We also, like the urgent cares, are testing. But testing is the name of the game, and that's where we are. So we're expanding hours as much as possible. And that's where we are. I will say something in regards to, as a leader of an organization, and I just talked to Columbus this morning. If you look at the CDC guidelines, you know, if you go on CDC, you'll see a mountain of information. As a leader, you certainly have to be very conservative because you do not want to tarnish any brand equity that you have. You need to make sure that if you have an employee that is positive, well, I'm sorry, first, you need to be very proactive and make sure that every one of your employees is testing for temperature every morning, non-negotiable. And what I'm finding a lot of organizations do is that when an employee clocks in, every employee has to clock in, that's hourly. They have to clock in and say, I swiped in at 7 o'clock. What I'm finding a lot of organizations doing is that they, at that point in time, are testing their employees for temperature. or the employee is attesting in the time and attendance system that they in fact did do a self check. Are they feeling well? Do they have a cough? Do they have a temperature? If they do, don't come to work. Some organizations are paying some organizations are paying the employee because employees feel like they have to come to work to get paid. They got to pay the bills. Some organizations are saying, you know what, the risk of you coming in and getting others sick is more expensive than me paying you for a day's wage. Different organizations are doing different things, but many organizations are saying, I will test you every time you come into work for you to say, no, I don't have a temperature, and yes, I feel good. Then you can come in. If somebody is positive, and what's interesting, a lot of employees don't get sick while at work. They get them because, you know, at night they might have gone to a graduation party, or this weekend they went to Put-in-Bay. A lot of the employees get their illness or the virus not at work, but yet they have it. So I would be conservative and say, okay, employee, you don't feel well, don't come to work. Go to your PCP and get tested, and tell me if you are not detected or detected. Until you can show me your results, you can't come back to work. If they do come back to work, or if they are tested, they're under the physician's care. Remember, we require an order for our tests. So does Kettering, so does Dayton Children's. That patient, your employee, needs to be under the care of the physician. And if that patient is positive, then obviously they're not coming back for at least 14 days or until they're tested again. Now, what do you do with everybody else? So if your employee did come to work and unfortunately they worked with 13 people, that's where the gray area comes. Do you tell the 13 people not to come to work? Do you tell them, hey, come to work, but we're gonna make sure that you do not have a temperature? I mean, that's the gray area, and that's depending on what you want to do with your organization. I've seen it both ways, but at the end of the day, you got to look at the big pictures. What's your brand equity? There's a lot of restaurants out there that right now are closed because they have 5 employees that have it, and now every patient, or every employee, or every customer that went to that company thinks they have it, and it's an equity issue, a brand equity issue. But that's kind of where we are, and that's my recommendation, and those are my thoughts. So that's my presentation. I am open for questions.
All righty. Well, if you guys do have more questions, I have a few in the chat. Just put them in. Here's the first one. Are you seeing false positive results? If so, what is the percentage you are seeing?
Sure. Okay, so false positives, rarely. If you think about what happens with your swab, you take the swab, no, we don't take it. We put the swab in, we take it, we send it to the instrument, and the instrument's looking for over 3 hours on a particular, they're looking for the virus, the SARS-2 it's got a long name. They're looking for that virus. If the machine doesn't find it, they won't report it. So a false positive is rare, less than 0.009%. False negative, that's where it's a little bit higher, meaning there's a chance of a false negative, which is the machine is not a good machine, meaning they're looking at it and they look at it for 10 minutes and they don't see anything and they say, nope, you're fine. But yet there is the virus on that slide. So that's where the difference between accuracy comes into play. If you have a good machine and it looks at it for 3 hours and it's sending gamma, it's looking at it, it's looking for 3 full hours. That's where sometimes the accuracy of some will say, nope, I can't find it. It's sort of like when I go upstairs and I look for my socks. I don't find it because I looked for 1 minute. I'm like, honey, I can't find my socks. That's where you're going to find false negatives. The instruments that we have are 99.5% accurate. That is what the Cepheids, the Lair, the Diasorins, and the Lycra, excuse me. That's what they were proven and validated through the FDA. We are at 99.5% accurate. which in the industry is on the very best of the bell curve. You're never going to find an instrument that's 100%, but being at 99.5% is what we have. So that's where we are with that.
Awesome. Next question I have, can anyone who wants a test get them, or must they be ordered by a doctor?
The answer is, well, there's two answers to that. Try to be black and white. If you go to a Premier Health CompuNet testing site, you do need an order, period. If you go to CVS, if you go to Walgreens, Rite Aid, you get a pharmacist order. The state of Ohio, through the CLIA licensures, which is our licensure entity, you do need an order. Now, the flip side, the state of Ohio, within the last 3 weeks, have set up these hot testing sites. They are not requiring an order. Their motive behind that is they want to test as many people as possible, whether that patient has a physician or not. Those are state-run. They are pop-up, meaning they're not here. They're here for 1 day, but they're gone the next 3. But for us, and for Kettering, and for Wilson, and for Wayne, and for anybody that is a hospital-based entity that runs with a CLIA license, you do need an order, yes.
As an employer, where do they direct team members that would like a test?
Yeah, so what they do is obviously, depending on the size of your organization, you might have an employee health department. And if your employee health department has a APN, or if it has a nurse, or if it has a doctor, they will create the order. If you don't have the size of that, and you go back to your employee and say, listen, you do have a temperature, you have to go see your primary care physician. What will happen is as Tom alluded to earlier, is that patient will probably call the physician office and say, hey, I have a temperature, I'm not allowed to come to work. That physician office, 99% of the time, will say, okay, we will write you an order to get tested. Those patients will come down to the UD collection site, or they can go to Wilson. They have a collection site. Wayne has a collection site. But the UD collection site here is the regional collection site when you have an order. That is the best mode to do that. Remember, not everybody can do it because a lot of people don't swab. They can go to urgent care, they can go to CVS, Rite Aid, or Walgreens too. They do swab. So there's that.
Awesome. Can you take a few more questions?
Sure.
Okay. Dale said, from the time you're exposed to the time you can detect, can you kind of repeat that a little bit?
Yeah, that's if you look at this picture, that is where you have the dotted line going down. That's you see no blue, you see no bubble there. Let's see, I don't know if you can see my screen here, but that's like day 0 to day 2. And remember, it's everybody human is different. Some it might take 4 days before it shows up. Some it might take an hour and a half. But there are a couple days here where you are not, it's before the PCR can ever detect it. That's also where you might have a false negative, meaning if you got a temperature today and you are so early on your incubation and you go get tested, it might not be there. The instrument looked, but you can't find it. That's where that baby blue bell curve kind of starts kicking in. That could be day 1. It could be day 1.5 or day 2.
Okay. The next question I have, do you know if insurance gets billed for pop-up tests run by the state?
The pop-up tents, no. The pop-up tents is a state-run, state-funded, state-led process. And no, they don't need an order, and they don't bill your insurance. Sorry. On the other side of the fence, when it comes to hospital-based, and for us and at Kettering and all Wilson, Wayne, Yes, we do bill the insurance carriers. The carriers are not denying anything. They are paying it, and never ever do we go to the patient. That's part of the CARES Act. That's part of what Donald Trump, the president, with DeWine established back in April when he met with all the payers, the CEOs, is the patient is never is not liable for any of the testing. Also, you could be tested every week if you want. You could be negative today, but get it next week. So we are testing sometimes, depending on the temperature, we're testing people multiple times. And insurances are not denying that.
How long is it taking for people to get their results back?
We're between 24 hours, 24 to 48 hours is when the results come back.
I can say that I had a test at UD on Monday at 1 o'clock.
Uh-oh.
I had my results by Monday night. So it was really fast.
We were busy, weren't we, on Monday?
Yes, you were. And I got
Oh
there
my
at noon.
God.
Yes, I might have, maybe I saw you. I don't know.
Yeah, I'm working the tent. The volume is,
I thought you looked familiar.
yeah, this is unheard of times, and everybody's doing things that they normally don't do. So no, I work the tent, and it breaks my heart. I mean, our volume is 500. There's just a lot of testing going on. So thank you for your patience.
Yes, it was efficient.
Thank you.
Bill, did you have a question?
Yeah. Just I'm just wondering, does the environment affect the test at all? For instance, if I come to your office to have it done, as opposed to I went through the VA. It was one of those drive-by type things where you rolled your window down, you gave your name, they swabbed me, and then I went on about my business. Does the environment affect that at all, or?
No, what happens after they take the swab, they turn around and put it in a cooler.
Okay.
The swab needs to be kept at room temperature,
Okay.
which is not 100 degrees on asphalt. But what they do is when you turn around, they put it in a cooler. So
Okay.
in our coolers, we have multiple coolers, and we're coming and picking them up every hour. In each one of our coolers, we have dry ice, so things are kept at room temperature. But no, now if we swab it and take that swab and leave it on a table,
right,
for a day, yes, that's a problem. There are labeled instructions clearly as to what we do with that swab when we get it.
Okay.
Some swabs, some vendors, some instruments require, once the swab is done, to be frozen, minus 40 degrees Celsius
Really?
within an hour.
Okay.
Some instruments don't require that. The ones that we use do not require instantaneously freezing.
Okay.
They are the ones that you can keep at room temperature for 24 hours, and it's once again, it's the instrument. Oh, yeah.
Okay. Thank you very much.
Okay.
Awesome. Well, I think that is all the questions that we have, Nick.
Thank you.